Next, I'd like to introduce Dr. Subodh Ganu. He is a Senior PICU Consultant and Deputy Medical Unit Head at the PICU at Women's and Children's Hospital in Adelaide. He's a committee member of the Paediatric Study Group of ANZICS in Adelaide and the Paediatric Representative on Point Prevalence Project with ANZICS. Subodh also holds a Master's in Clinical Epidemiology and Biostatistics from the University of Newcastle. His work-related interests include clinical research, use of clinical information systems, electronic documentation in ICU, continuous renal replacement therapy, ethics in acute care medicine, and brain death and organ donation. Thank you.
Good morning, everyone. And it's a bit daunting task to talk after two such great presentations, and I'll try to do my best. I think it'll be justice to the Open Heart International, on whose behalf I am here. So as you have heard, I am a full-time practicing ICU consultant in Adelaide, and every now and then, in the month of June usually, every year for the last 4 years, I have been to Fiji and get my registration done for pediatric ICU with Fiji Medical Board and fly with the Open Heart International for managing and setting up the cardiac PICU there. Can't thank enough to the OHI team as well as Ministry of Health in Fiji and the Sydney Adventist Hospital who started this whole initiative quite a few years ago. I think it's been the first Tongan OHI mission happened in 1983, if I'm not wrong. So the Fiji missions have been going for more than 25 years. So can't thank them enough. Well, when I first visited Fiji, it was when I was a tourist, and I had just passed my ICU fellowship exam, and I was in a totally different mood I did not even leave the island where we went for a family holiday, and I was just chilling out. But since subsequently from that onwards, I would like to show you a different Fiji. So we're going to go on a journey and take a flight from Adelaide to Fiji, where we, instead of focusing on the beautiful beaches, the snorkeling, and the scuba diving, we're going to talk about how to come and manage these challenges that they have. Not only global warming, which has been in the media and the limelight last few years, but the health concerns, especially with children. So even Paradise comes with the challenges. The Fiji population they're a very young nation, around, as you can see, more than 50% of population is less than 50. From their pediatric point of view, they classify anyone less than 14-year-old as a pediatric patient, so that comprises around 30% of their population. And mainly, although there are only two big islands that you're seeing usually on the map when you Google it, I'm sure you probably all know this, but there are 300 islands, and almost 100 or more than that are habited by human population. So it's very difficult to cater for such a large territory which is separated by a vast amount of water. And it is, if you ask about, usually the developing countries, what are the major problems that are causing years of life lost? It is changing. If you look at that, the congenital defects, as Ranjan said, most of the congenital defects are heart defects, which will end up in causing years of life lost. They were at number 10 in 2005, and with improvement in socioeconomic state, control of infectious diseases, they're moving up. So it's becoming number 6 already in 2016. Obviously, still the first 3 top ones are the adult chronic comorbidities that come along. The existing services for especially children and also some adults in Fiji are basically focused on 3 government institutes. One in Suva, which was the first hospital, the Colonial War Memorial Hospital. One's on the western side of the main island in Lautoka, and then Lombasa. These are the 2 biggest islands, and essentially those 3 hospitals have some kind of pediatric ICU facilities and some pediatric surgical facilities for the children. So all these other 109 or 107 islands need to move the patients to these islands if they need any significant life supports. There is a lot of discrepancy between pediatric and adult ICU services, sadly, and it's really difficult to imagine working in their pediatric ICU if you haven't been there before. The PICU, Fiji PICUs are, you can compare to level 1 or level 2 ICUs. They are quite overwhelmed and always full with medical patients and injuries or traumas. They mainly do single organ support, like ventilation. At times, they might not have enteral CO2s for each and every bed space. They certainly don't have any invasive pressure monitoring capabilities in their current ICU. So they don't have the pressure monitors, not the transducers, and that comes with a huge challenge of monitoring anything cardiovascularly. Even running inotropes for a longer time might be a challenge. Having known all those things, and these are the things in 2018 when I've been recently there, so imagine what it would have been when in 1990 when this all started. So where and how we start for the next trip is the real question. I think what has happened in the past, the things have evolved, and we learn from the past experiences. The planning, to be honest, begins almost the year before. When I've come from the trip in June, I start planning how am I going to do it for the next year. And I'm sure a lot of you, I can see familiar faces who do other trips with OHI or for some other cardiac trips. The planning goes a long way back, not just during the trip or just few weeks before that. There's a lot of logistical and the interdepartmental and governmental issues in getting mutual approvals for the teams. Fortunately with Fiji, because OHI has been going in for 25 years now, it's been streamlined quite well. But every now and then there are political and unstable environments that puts the teams at risk, and then you have to cancel the trip at the last minute. There also needs to be agreement with the local hospital, and not only just at the hospital, but at the lab level, at the local pediatric team level, at the theaters level, to give us a space that we're going to need to operate on these children and adults. Certainly the lessons learned from years where you've been adding to the experience with the OHI help a lot. So what happens with the individual patient when it comes closer to the actual trip? Usually the local team would have identified the eligible or likely patients that have congenital heart disease. They have an excellent cardiology team who is very good at doing echoes with even limited resources like Sonosite M-Turbo, the machine that was there in our ICU probably 15 years ago. They still do very good echoes and do diagnostic cardiac diagnosis. Then these patients get clubbed together, and the OHI cardiology screening team with a cardiology consultant and echo technician visit usually a couple of months before to not only to the main Sua or Fiji island, but also to other islands where they run many clinics, sometimes fly in the morning, fly out in the evening, doing a clinic a whole day to screen these patients and selecting carefully those children who would benefit and who would be a one-time fix from pediatric cardiac surgical point of view. You don't want to have kids that would just get into trouble subsequently and would need revision surgeries because there's lots of issues with follow-up and patient adherence to treatment. Then you bring those patient lists back. You discuss with the main team in SUA, in CWM, or the Colonial War Memorial Hospital. Do you have discussions with the family? A lot of times there is big concerns about transporting these patients to the mainland, and you basically prepare them for surgery. These kids come with their other comorbidities, such as infections, skin diseases, nutritional issues, and all those, if in advance get addressed, you have much better post-operative course. So selecting the right patient is quite important, and I think our cardiology team does excellent job in that. Then you have a planning teleconference once the patient list is getting finalized, and you decide the sequence of the patients. A lot of people are involved in that, and one thing that is a little bit different, this all gets done by the cardiothoracic teams here, but one thing that is different in Fiji is you got to look at whether I'm going to get this patient out in 7 days out of my ICU, because there's no way that this patient will be supported after that to the same level where I can support them during that period of time. So those patients who are going to spend a bit more longer ICU time will need to be operated within the first 2 days, and then you have to think about it. What are the resources I have? And I'll come to that in detail subsequently. So what do we pack? When we got the list, of the patients, then we know what kind of equipment we're going to need. Now, having said that, these equipments might be available locally, and most of these equipment to some degree are locally available, but it is difficult for them to be available in abundance and at a level where we can just pick up another ventilator when the child is needing emergency intubation. Their ICU resources are stretched so much with the medical patients that we take all our ventilators with the OHI, all the infusion pumps for cardiotropic drugs especially get taken over there. The monitors, thankfully, over the last 4 years, they've had an upgrade in their cardiac theater for adults and the adult surgery side and the recovery side. So they've got quite good monitors, although with transport monitors we struggle. The echo machine gets taken out for the adult guys to do toes, so I can borrow the machine if I need to. One of the important things is these are big ticket items, but the small ticket items, which I don't usually think about when I'm working in ICU here, are the most crucial ones, like line extensions, the small, low volume arterial line extensions, arterial transducers, and their compatibility with the monitors in Fiji, small size suction catheters, because this is an adult recovery and adult theater that we convert into pediatric cardiac ICUs. These things are not available in abundance, and we have to take them along with us. Along with that, we need to take some pharmacy medications and labs. Now, we can't take Schedule 8 drugs because internationally you need a special license to move opiates and sedatives. So those we have to locally resource, and we have to rely on what formulations that they would have. So there's a little bit of a learning curve if the formulations have changed since you've been there last. The fluids are provided by them. They have almost similar set of fluids. One of the interesting things is that muscle relaxants behave differently. Sadly, when they have a very long onset time, and then the kids are waking up partially muscle relaxed at times, which is a big challenge. So you have to predict the duration of action of these agents. Their emergency drug protocols are essentially not readily available, so I print off all the emergency drug protocols and the infusions of cardiac drugs and things like that. That's what you would do in your normal ICU in adult or pediatrics. So the team arrives with all the equipment being shipped, and then there's a huge task for obviously around the whole day of after getting there is to set up the equipment, put the pieces together, do the troubleshooting. There's always some last-minute hiccups where this one doesn't behave properly, that one doesn't behave, that needs a bit of clean. The equipment get function checked, you decide the bed layout, you usually decide, when I've been there, there's always an adult parallel program going on as well. So we have to distribute the beds or the sizes in the space available. We set up the emergency contacts, so they import all the people get mobile phones and also the phone numbers for the local teams. And it's quite important to get the local team and then understand what has happened since that previous teleconference when we got there, how many patients are we planning to do in the first few days especially. Setting up the PICU itself, that's how it looks like. It's a very rough diagram. I apologize if things are not clear, but essentially the P's are the pediatric bed spaces. P/A is where we can take a small adult or a big pediatric patient, and A's are the adult ICU patients. There are usually 3 or 4 pediatric surgeries happening every day, and usually 2 or 3 adult valves. So I get a bit more area, but there's always a challenge in setting up the monitors, and there's a visitor entry to the recovery. There's a visitor entry to the recovery where the parents can enter, but as you can see, there's not much space for the parents to spend at the bedside for most of the day. So they keep coming and going, and there's a separate entry from the operation theater where the patient gets wheeled in. This is how it looks like when there's nobody there. So these are recovery beds, so they don't have a lot of space or privacy in between. You can see the curtain railings, they're quite close together. What is another challenge is actually there are hardly any power points, more than 2 or 3. So you've got to ration what equipment is going to be charged, and extension boards and things like that. You have to set them up in a most safest way that you can. The monitors are pretty good. They're usually useful, but they're quite high for my height. It becomes harder to reach at times. this is how it looks like when we have all set up. So we set up a little, depending on what the first few patients are going to be, we can either have a cot or the neo cot that we can borrow from their NICU if it's available, or we use radiant heater. There's a little ventilator that they had actually kindly given it to us for a few days. And we use the boxes as a nursing, as a support, and chairs and things like that. Improvise. The last minute huddle usually happens in the evening when we have all set up the equipment. The theaters have set up their theater things, and the bypass machine has had the first few hiccups and trial runs and things like that. The bypass machine, by the way, is the most biggest and the heaviest item, so it gets left there, and it basically gets used by the cardiac teams whenever they go. You do the equipment check, you do the patient status check, you look at the staff issues and the rosters. I usually don't have anyone to relieve me, but thankfully this time I had my fellow with me, and we kind of looked at the list and looked at, okay, this is going to be the busy night, this is going to be okay, so we'll split ourselves into a day and evening kind of a roster and then get a bit of a break in between. What we do is also in that meeting, we set up some ground rules that there are lots of doctors involved in this care. These patients are managed in the pediatric side of the hospital, which is around 200 meters away in the same premises. So they get transported into the adult side of the hospital. There is anesthetists, surgeons, but ultimately it is important to get those patients out of the ICU into the ward and almost ready to go back to the general pediatric ward by the time we leave. So we get to have the intensive care team needs to be switched on to look at the sequence of surgeries. A typical day is usually like you would be practicing in your adult or pediatric cardiac ICUs, rounding at 7 a.m. with surgeons. Then you plan for the list of the day, look at de-intensifying the patients that are in the ward. Then you go to the ward, look at the previous ward transfers, and these rounds are usually done with the local team, and at times the local team helping with post-op echoes. And by around 11:30, 12 o'clock, you start preparing for the new arrivals. The surgeries can go on for a long time, so the last patient can come around 9:30, 10 o'clock in the night, and then the low cardiac output stayed and managing them overnight. So you got to pace yourself for 24/7 for 7 days. As I said, it's great to have another person helping, or sometimes the adult ICU consultant also helping out. Discharge planning is a big deal because you need to absolutely specifically mention what is going to happen with these patients and plot a trajectory and a flow diagram for next 2 weeks or so. Tell them what post-op imaging they're going to need and the tests. And good thing about OHI now is they've got a follow-up protocol for these patients for the local team up to 2 years. And the ward transfer and the handover from whenever these patients move from one place to other can't be less emphasized. This is the snapshot of a busy ICU. I've got 5 patients that you might be able to see, 1, 2, 3, 4, and there's one on the adult, one on this side. As you can see, most of the nursing obs at this stage of the day are done by the local team. So there are local recovery nurses and the pediatric nurses with varying experience. Some are neonatally trained, some are not. They would be coming in and doing some day and night shifts with us. So it's great to have them. But as Ranjan said and Georgia said, not everything goes according to plan. You have issues when at the last minute when you arrive, you have a patient that was a week-old TGA with no other risk factors, good weight, 3.8 kilos, and the surgeon thinks, can we operate? And we say, okay, if you want to operate, do it on the first day because you're going to leave the chest open. And we do then try and do the best for this baby. Otherwise, this baby would be, this poor family will probably not be able to get to either New Zealand or India where they would have to fly out. But that funding and everything gets around $25,000 to $30,000 and usually gets delayed by at least a month, which is not an ideal situation. So there are things that don't go according to plan, like extubations. We have a limited number of ventilators, so we have to think about cleverly extubating the patients right on time. Some babies, as I said, it can be difficult to predict the muscle relaxant offset. And although they are wide awake at 1 minute, the next minute they start snoring and start obstructing. Getting bed ready for the next patient is a challenge, especially when the surgeon is very quick, and they are sometimes. And although not a bed block as such, I would say it's a bed management issue, which is always we're struggling with, and staff management and looking after them as well, because there are usually there are 3 nurses in the night, 1 on the adult side, 2 on the pediatric side, with the local team helping, and a similar in the daytime in the ICU. So some numbers that we did this year, as you can see, the first one was the aortic, is this working? Valve replacement. There was a big girl that was looking at the bypass machine and things, making sure things are going well. Then the TGA baby that we did came back with the open chest. We got chest was closed on Wednesday and got extubated on Thursday. Then subsequently ASDs, VSDs. As you can see, there are very few valve replacements or rheumatic heart diseases, because they need a lot of follow-up and anticoagulation, and the quality of life will not be as good as fixing a congenital heart disease. But this is just one trip. It's been going on since 1990. Only 3 years that they haven't been, OHI hasn't been able to, because of the political issues and the military coup. Around 20 children a year, and not only Fiji, but we have more than 150 projects in various countries and still going. So follow-up and winding up is a great emotional day. Look at our smiley faces when the last patient is getting wheeled out of ICU. We are relieved, but the job's not done. These 3 boys were actually very good friends. They come from same school, and if they're walking around in the wards 2 days post-surgery, you won't believe they had cardiac surgery with the jumpers on. We used to call them the rugby team. And usually you don't come back till you think about doing it again and trying to learn from the experiences that you have had. These are the trips that the OHI does. This is their 2019 calendar, and they're always looking for volunteers. The number of trips have gone up so much. I was talking to Michael Weir the other day. He was saying that he's looking for people all the time, and every now and then we get an email that they're short of a key person. This was our team in 2016 when I went there. So if you are thinking of volunteering for OHI, it's a great experience. And just click on that link and please register yourself as a volunteer, not just expressing the interest. And if any help I can provide, I'm always happy to be contacted. Thank you.
Thank you, Subodh. Unfortunately, we've run out of time for questions in this session, but thank you very much.
Thank you.